matters is the L5 foramen. So patient with isolated L5 foraminal stenosis, your options, you can decompress and fuse, or you can try a motion preserving or dynamic stabilization technique. So again, I have a couple of disclosures. I mentioned these yesterday. I'm a consultant for Stryker. I am a shareholder in 2 companies. However, the most important disclosure I have here is generally I would not use a TLIF for isolated foraminal stenosis. So I'm kind of arguing something that I really don't believe. But so, you know, again, always go back to what are the goals of your surgery. The goals of treatment of foraminal stenosis: to improve symptoms, you need to increase foraminal volume somehow, and you need to maintain or restore stability. So do we need to fuse when we're looking at it? Well, if the patient has instability, fusion patients do better. Okay, that's from Zoe Gogowala. Many patients, though, I still believe many patients will benefit from foraminotomy alone. My experience if I decompress an L4 foramen, there is at 1 year a 5% recurrence. If I decompress an L5 foramen at 1 year, there's a 20% recurrence. And that's where the problem is. And so in my case, I reserve fusion for people who fail a foraminotomy the first time around. But this is the key, and this is why it's the L5. It's the so-called up-down stenosis, the shortened interpedicular distance. You can remove bone dorsally, but if the foraminal volume is low because of a small interpedicular distance, you're not going to improve foraminal volume. And I don't think there's any way to increase interpedicular distance without some form of instrumentation. But if you're going to do a fusion, you need to increase that interpedicular distance, and that's why I think you do need to do some form of interbody fusion if you're dealing with quote, up-down stenosis. The interbody fusion also gives you higher fusion rates, and again, better restoration of lordosis, which is probably correlated with better long-term outcome because of less adjacent segment degeneration. And just quickly, what are your options for interbodies? You all know this. TLIF, you can do a TLIF, MIS, or open. You can do a PLIF. My personal preference for isolated L5 foraminal stenosis is an L5S1 standalone ALLIF. And then you do have the options of LLIF or anterolateral, anterior to psoas, OLIF, whatever you want to call it. The advantage of TLIF, it's well understood. We do it commonly. Again, can be done open or minimally invasively. Does TLIF restore foraminal volume? Yes, multiple studies have shown that it restores foraminal volume, and so does decompress. The advantage, again, commonly done, high fusion rates. You don't need an access surgeon. We're used to doing this. Why use an ALLIF? Highest fusion rate of any fusion technology. Excellent, best restoration of lordosis. Low complication rate. It is a minimally invasive procedure if done through the mini open approach. Why not use it? Well, some cases it's a 2-stage procedure. Risk of vascular injury, it's actually quite low. It's about 1%. Risk of retrograde ejaculation, very technique dependent. You'll see in the literature rates as high as 24%. Personally, in my hands, in over 1,000 of them, I've had 3. So it's very low. The other problem, reason many people don't do ALLIFs is the need for an access surgeon. The data actually does not show an advantage to having an access surgeon. The data shows that spinal surgeons can do it with the equivalent complication rates, or in fact, in one of the studies, lower complication rates. Do you need posterior fixation with an ALLIF? If they have an intact posterior tension band, no, you don't. If they don't, if their posterior tension band is destroyed, so they have a spondylolisthesis, they've had a complete laminectomy, you probably do need to. Some people do use anterior plates with an ALLIF. I've had bad experiences with them, so I don't. So my preference, if they need to go posterior, is to use percutaneous screws. Again, MAS lateral fusion, probably not going to be a big thing for foraminal stenosis because the bad actor here is the L5 foramen down at the bottom. So you really can't do the lateral there, though the OLIF can do that. And again, we've had a couple talks about the advantages of that. And again, the advantages of the direct access: no need for vascular mobilization. You avoid the vascular and autonomic nerves, and you can put in a large cage with good lordosis. And in a patient like this, it's much easier to go through the side because that pannus hangs forward than to try and go through the front or from the back. So what are the results? There are no good long-term or comparative studies comparing the interbody techniques to fusion or to decompression alone. All of the interbodies have high fusion rates. All of them have low subsidence rates. All of them are well tolerated, so any of them is an option. And there's my quick look at use of fusion for foraminal stenosis.
Any question or comment about that technique? Doc, you presented it is a very easy procedure and without complications.
Which?
With the interbody fusion.
I think it is.
Okay, in your hand.
Yeah.
Yes, one more question.
You mentioned the up-down stenosis.
Yeah.
What about the lateral?
What do you mean by lateral stenosis?
Mini lateral.
Yeah, so again,
posterior.
the